Hello, everybody. Welcome to tonight's virtual information event. This is my first one, so please bear with me. It seems very strange talking to yourself, so I'm hoping that you can all hear me. So my name is Kathryn. I am the lab manager in Nottingham, and I've been an embryologist at Care for 23 years. So during this time, I've seen many exciting changes and increasing success in making families. So tonight's event is Paths to Parenthood. And I'm going to be giving you all the information you need to get to parenthood and answering your questions at the end. So I'll be going through diagnosing a fertility problem, an IVF treatment pathway, treatment with donor eggs, sperm and embryos, the lab techniques we use to help improve your chances of success, support at care, funding your treatment, and getting started at care with a video from our patient inquiry team leader, Shah. Then we'll have a questions and answers session where I'll be joined by Professor Charles Kingsland. And then you can answer questions throughout the evening in the private questions tab or in the public chat where your first name will be visible to everyone on the chat. Or you can send an email to events@carefertility.com. If we don't have time to answer your questions during the event, we will reply via email. And if you think of any questions after the event, our patient events team will reply as soon as they can. Also, the patient inquiry team are available until 8 p.m. tonight, and you can reach them on 0800 564 2270, and I believe that number is in the chat as well. And then we'll wrap up the evening with a message from our CEO about life at Care and our dedication in supporting you on your journey. So I'd first of all like to show you a short video introducing Care.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are Care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with, I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way. And I feel like they lived the journey with us.
So I've had several treatments with Care. I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
So the actual number of Care babies now exceeds 60,000. So we need to keep updating this presentation. 1 in 6 couples need help starting a family, and we're here to support you. Here at Care, we have 14 clinics all around the country, and each one has experienced and expert clinical teams. So no matter how complex or simple a treatment may be, we can guarantee that there will be someone in the team who is specialised in the area and can really help to make the difference. During tonight, I will be referring to the general IVF process, but whether you are having treatment with your own eggs and sperm or with the help of a donor, the principles are the same. It is really easy to get started at Care. We have a new patient inquiry team who are very knowledgeable and can answer all your questions about getting started and about your treatment. The team are available until 8 p.m. this evening, and Lauren, a member of the team, is available right now to answer any questions in the questions tab. So, getting the right diagnosis is key, and we take the time to get to know everything about you before you start, including a detailed medical questionnaire, and all the information is reviewed by one of our consultants prior to the initial appointment. Each patient will set up a secure online patient portal for all information related to their treatment in one place, and you can upload previous medical notes and test results onto the portal for live viewing. In your consultation, your fertility specialist will listen to your fertility plans and wishes. They'll explain your test results and the need for any further tests and why they are necessary. They will discuss the different treatment options and chances of success. You'll be given a detailed plan about your treatment options to go away and consider in your own time. And you'll be provided with a cost estimate and also given all the time you need to ask any questions. So after the consultation, you'll have an idea of your individualised treatment plan. And this may not be IVF in the first instance, it could be IUI or fertility medication. However, tonight, because the majority of treatments involve IVF, this is a journey that we'll discuss. It starts with ovulation stimulation. This is prescribed medication to stimulate the ovaries to produce follicles, to produce eggs. You'll be given the medication protocol by the nursing team, who will explain to you how to prescribe the medication and also support you in following the protocol. There is also online injection videos to remind you how to do this and to follow along at home. So whilst you're taking the medication, we will be monitoring the follicles by ultrasound to find the correct time to collect the eggs. The monitoring phase usually lasts between 3 to 7 days. And once you're ready, you'll be given an injection to trigger ovulation, and you'll have your egg collection 36 hours later. The egg collection is a straightforward procedure performed under ultrasound guidance in one of our theatres. A needle is guided into the ovaries and extracts eggs from the follicles. This is usually performed under nurse sedation and lasts a maximum of 30 minutes, followed by a short rest, just enough time to have a cup of coffee and a biscuit, and then you're ready to go home. The sample is usually given at the same time as the egg collection. There can always also be collected with minor surgery if there is an issue with getting sperm from the sample. So during the setup of your treatment, you will have provided a semen sample for analysis so that we can tailor the treatment to the sample. So during the analysis, we look at the sperm concentration or the number of sperm. We look at the motility of the sperm, if it's moving and how it's moving, and the morphology of the sperm. That's how each sperm looks, its head shape and its tail structure. This allows us to build up a picture of whether the sample will be suitable for IUI, IVF, or ICSI. So the eggs can be fertilised by IVF or ICSI. IVF is where the sperm is put into a dish holding the eggs and allowed to enter the eggs naturally. Whereas ICSI is where we inject a single sperm into each egg. So the method of fertilisation is decided before the egg collection, but our embryologists always check the sperm and egg quality on the day to ensure that everything is okay for the planned treatment. So on the day after the egg collection, the embryologists observe the eggs and can tell if they have fertilised or not. So a fertilised egg has 2 nuclei within it, one from the sperm and one from the egg. So the embryologist will ring you in the morning after they have checked the eggs for fertilisation and pass on all the information to you at that point. We will discuss how we expect the embryos to develop and explain when the embryo transfer, biopsy or freezing will be. We will also provide you with a detailed information about the expected embryo development to your patient portal for reference at home. And we know from experience and our expertise that to maximise embryo development, we should leave the embryo in the incubator to develop in their optimal environment and in their specially designed culture media. We're constantly using our combined depth of experience and specialist knowledge in embryology to employ procedures and technologies to maximise the chances of success with the embryos we have created. Again, everyone is different and we individualise our tests and procedures in the lab to help you maximise your chances of success. Tests that we can offer, such as SOS and Care Unity. Procedures we can offer include PGT-A, and a technology that we are very proud of and proud to offer is Care Maps. So the time-lapse incubators we have allow us to build up a video of embryo development, and using technology to compare in-house embryos that have produced a live birth and those that have not, we've been able to build an algorithm called Care Maps, which ranks the embryo's development to help us to select the embryo for transfer with the highest chances of producing a live birth. And we are also very excited to present our latest in-house artificial intelligence in tandem with the success of Care Maps, whereby AI is used to investigate, interrogate, and record the embryo development, and then apply the Care Maps algorithm. So the embryo transfer is again done under ultrasound guidance. However, there is usually no requirement for sedation. The embryo is loaded into a soft, fine catheter and inserted through the vagina and cervix and into the uterus. It is a 15-minute procedure and there's no requirement to rest afterwards. And then comes the 2-week wait until the pregnancy test. So the care nurses will be on hand to guide and support you during this time. You'll have progesterone to aid the implantation of the embryo. And if you have a positive result, you will have a scan at care and then be discharged to the care of your GP. And if you have a negative result, you will be supported by the nurses and the counsellors, and we will arrange a follow-up consultation as soon as you're ready. There are many different reasons why you might need to use donor eggs, sperm or embryos. And our donation team have over 25 years experience and have helped more people to start a family with the help of a donor than any other UK clinic. They will support you throughout the entire process, from initial questions through to helping you to select your donor and specialist counselling. Now, we realise that support is an integral part of the journey for patients. Every team at Care is developed to provide patient support, to ensure that support is available at every moment during your treatment. We also offer free counselling appointments. They can be face-to-face, online or over the phone. And we have a Care social media presence and also a 24/7 Care online forum for you to chat to other patients. Now, we're here to support you medically and emotionally, but we're also financially too. So Care Pay is an exclusive, individually tailored IVF funding packages designed to give patients the financial peace of mind, knowing that a plan is in place to fund treatment. And we've created Care Pay following patient feedback that it is disruptive to have to contact someone else to access the funding programs. So Care Pay is managed entirely by our in-house teams, so patients have a seamless experience and their treatment is personal and private. All Care Pay programs include cycle monitoring, egg collection, embryology procedures, unlimited embryo transfers, freezing and storage, and Care Maps as an extra benefit to help you give you your very best chance of success. So thank you for listening. And now we will move on to the question and answers session. So don't forget you can ask questions in chat, questions or via email. Now let me introduce you to Professor Charles Kingsland, our group clinical director in person, to help me answer your questions.
Hi, Kathryn. Can you hear me?
Hello. Yes, I can. Thank you.
Good. Well done so far. You're doing really well.
It's very odd talking to yourself.
Yeah. Well, I've been talking to myself for years, so it's not odd for me anymore. But before I start, Kathryn, I've just reminded myself that I owe you a paragraph on embryo transfer.
Oh, you do? Thank you.
I'll let you. I'm writing it as we speak.
I'll hold you to that. Yeah.
Yeah. As ever, there are lots and lots of questions, Kathryn. So what I'm going to do is I'm going to go through a few, and I'll obviously ask your embryological expertise if necessary. And if there are any questions that anybody wants to save till later, our girls will be happy to answer that, to take those questions. We can answer them after the program. Okay, so I've got a question here. Why do PGT tested embryos fail or result in miscarriage? Well, PGT stands for pre-implantation genetic testing, and that means we take the embryos and we take a little biopsy from the embryos and check the genetics, the chromosomes, to see whether they're normal or abnormal. What we have to remember is that humans do not make completely normal embryos all the time. Those embryos can be abnormal, genetically abnormal. That's why we don't get pregnant every month. And as you get older, the number of embryos that you create are increasingly genetically abnormal. And what Kathryn has described is something called care maps, which we're very proud about, which gives us an indication as to what the embryo is like on the inside. It's a morphological assessment. That means we assess what the embryo, how it's grown, how it's developed, and that gives us, we put all that data into our computer bank, and that gives us an indication of which embryos are likely to turn into babies. It doesn't tell us which ones will actually turn into babies, but it gives us an indication. The next thing, the next more sophisticated test, is to biopsy the embryo. Now that's a little bit more involved, but it can be done, and we recommend it in some patients, not all, but occasionally if you've had a miscarriage, or if you're a little bit older, it may be that pre-implantation genetic testing is for you. Now, if we do the biopsy and the embryo is normal, that increases your chance of having a healthy baby at that time of embryo transfer. But it can never guarantee, because although the embryo is the most significant indicator in what creates a healthy baby, there are other things. There's the uterus, there's the lining of the womb, there's whether the endometrium, that's the lining of the womb itself, is in the right phase or not. These tend to be less significant, but they're also important, and they can help. Sometimes testing of the endometrial phase or the uterus itself can help in improving the pregnancy even further. But we have to accept that in some cases, and it's very unusual nowadays, the embryo might be normal, the endometrium might be in phase, but a pregnancy just doesn't happen. All you can do then is to reassure yourself that you've done everything you possibly can, but that's just beyond the technology that we have available. As Kathryn said, the technology is improving year on year, and it's fantastic now compared with what it was 25 years ago. But still, there are facets of the treatment that we don't know about, and we're working hard towards gaining even more knowledge with artificial intelligence that Kathryn has mentioned, etc. But usually we can find a reason as to why the embryo doesn't implant. So what I would suggest to you is this lady or this couple go back to their consultant and just ask the questions. Is there anything else, any other tests that they need to do? Is there anything that we learned in the previous treatment cycle that we can improve on in the next one, or make the endometrial environment even better, so that normal embryo gets put back at exactly the right time, at exactly the right place? Would there be anything you wanted to add to that, Kathryn?
No, that was what I was going to say, that there could be other abnormalities within the embryo, that we can't yet test for, and hopefully those things will happen with time.
Yeah. Why is it recommended to wait a few months between a fresh transfer and an FET, a frozen transfer? Well, nowadays, many of our embryos we can freeze very safely and very successfully. So it separates the creation of the embryos from the replacement of the embryos. As Kathryn mentioned, when we create embryos, it's essential that we stimulate the ovaries safely on the minimal dose that is safe, but in order to collect as many healthy eggs as we possibly can. Once those eggs have been collected, we then hand them over to the embryologist who work their magic and make embryos. And the more embryos that we get, the better chance we have of achieving a pregnancy. However, during the initial phase of the treatment, we have to stimulate the ovaries with hormones, and they can, whereas they're great for stimulating egg growth and development, they may not be brilliant at creating the right environment for the embryo to go back. So it's sometimes beneficial to get those hormones out of your system before you put the embryo back. And so we normally recommend 1 or 2 months to rest after your fresh embryo transfer, just to let everything settle down and get back to your normal pre-IVF state. So then we've got a sort of a clear playing field to put that embryo, your next frozen embryo, back in the best environment possible. So therefore, we normally ask you to wait probably 2-3 months for no absolutely proven reason. But the other thing is, IVF is a very stressful time in your life. Not only have you got the stress and the worry about starting a family, but you've got the stress about the treatment itself. And we should never underestimate how stressful that can be. And when you've been through an IVF treatment, you might need time to just reflect, chill out, maybe go on holiday before you come back and have the next phase of your treatment, which is usually a frozen embryo transfer. So that's what we normally say. Does IVF reduce the chances of embryonic occurrences, i.e. an empty sac? That means does IVF reduce your risk of miscarriage? Well, not really. What can reduce your risk of miscarriage is if you have your embryos biopsied, and then it doesn't increase your chance of a live pregnancy, but it reduces your chance of having an embryo put back that may be genetically abnormal, which may not implant, which may not create a pregnancy, or if it does implant and create a pregnancy, may go on to miscarry because it's genetically abnormal. So if we knew the genetic makeup of that embryo, then and it was normal, we put it back, and that would actually reduce the chance of you miscarrying. If we don't know the genetic constitution, then we can't really reduce the risk of miscarriage. And that's why often we'll say, once you're pregnant, you're a 35, 34, 38-year-old woman having a baby, you're not at any increased risk of miscarrying because you'd had IVF. IVF doesn't increase your risk of miscarriage, but you've got all the chance of miscarrying as any normal woman would have. And that increases as you get older. Not if you're 38 and had IVF, that doesn't mean say your chance of miscarriage is going to increase over and above a 38-year-old who's got pregnant without IVF.
As far as the empty sac is concerned, one of the things that we do to morphologically select our blastocysts is to ensure that they have an inner cell mass, which is the clump of cells that become the fetus. The hypothesis is that an empty sac is a blastocyst that's developed. The trophectoderm cells around the outside of the embryo, but not a viable inner cell mass. So although we can't see that it's viable, we do see that it's actually there. And there are some blastocysts that develop really beautiful trophectoderm cells with no visible inner cell mass.
And can care maps help that, Kathryn?
Yes, yeah, obviously it helps us to see, because we're not just taking a snapshot of the blastocyst, we're watching it as it actually develops and forms, so we can clearly see how that inner cell mass and those trophectoderm cells are differentiating within the video. So yeah, yes,
and that's I think that just exemplifies what we do at Care. You know, every patient that comes to us, we like to treat them all as individuals, and every patient is managed on their own individual merits, and that's why it's essential that we have the dialogue between the embryologists and the doctors, so that we can combine our knowledge to create the best embryos and put those embryos back into the uterus as safely as possible to give you the best chance of getting pregnant. Another very advantageous factor is that we've got so many clinics around. We now have 60 consultants, all with particular specialties, so we're able to discuss more challenging cases with our colleagues throughout the UK. So you may be being treated in your local clinic, but you've probably got the benefit of our knowledge from all our clinics all over the country. Like, for example, Kathryn in Nottingham, myself who's based in Liverpool, we have London, Birmingham. We can all converge and discuss these particular cases and give you the best advice to achieve a family. Right. Can low AMH affect IVF? Yes, it can. AMH is anti-Müllerian hormone. It's the hormone that's secreted by your eggs, or the little cells that surround the eggs. It doesn't tell you about the quality of the eggs, it tells you about the quantity of the eggs. So a high AMH gives us an indication that you might get a high number of eggs. A low AMH is a low number of eggs. It doesn't tell you about the quality. Sometimes it's probably better to have a low AMH and be younger than have a high AMH and be older, because all that means is you might get a lot of when you're older, you might get a lot of eggs, but they are older eggs, and therefore they may not be as good quality. They might be, but they tend not to be. So AMH gives us an indication prior to stimulation of your ovaries as to how many eggs we think we're going to get. And obviously, the more eggs we safely collect, the more is the chance of getting good quality eggs, and the more is the chance of those good quality eggs turning into good quality embryos and good ongoing viable pregnancies. It's just like picking apples off a tree. The more apples you pick, the better is your chance of getting a good quality apple, but you have to pick them at the right time, and that's the skill of stimulating ovaries as carefully and as sensibly as possible, and collecting the eggs at a time when we think you'll get most mature eggs, and they're the ones that we want to create the best quality embryos. Anything you want to say about that, Kathryn?
No, I don't think so. That about sums it up, really. Thank you.
Okay. Is there anything I can do to improve my chances of more embryos for my next cycle? Yes, there are always things we can do. I know it's often people say, oh, well, IVF, the first cycle is a practice cycle. Well, it's not. You know, we provided, as Kathryn said, we've taken a meticulous history, and we know what your background is, and we know what the sperm is, what the quality of the sperm is, and the your AMH and your ultrasound scan and your past history. We can then tailor your individual treatment to give you the best chance first go. However, some people are not successful on their first attempt at IVF. They may have spare embryos that we can use subsequently, but the first IVF cycle gives us a lot of information that perhaps we can use in a subsequent cycle. So, you know, you need to treat IVF as a course of treatment, not necessarily just a one-off hit. it's a marathon, really, not a sprint. And many of you will have known who've already started IVF. You know, it's not a sprint. It's a long journey, but it does have a beginning and it does have an end. We have to make sure that journey is of the highest quality to give you the best chance of a good finish. But so the first IVF cycle can often be a really good learning tool, and we can take what we've learned from that cycle and change and alter and tweak for the next cycle to give you an even better chance. So but never feel that the first one is a sort of an experiment. It's not, because we can plan the first cycle very carefully, but there are always things you can learn. Anything you want to
very true
say
yes.
about that?
Yeah, I mean, yes, but because we're seeing the embryos develop in such minute detail now, obviously we're gaining so much more from seeing every individual's treatment, and we can pick up so much information from how their embryos develop.
That's right.
Obviously, we never had it before because we didn't have the time lapse incubator, so it's all new information to us. But also, there's no way of predicting that without actually having the embryos there. So
I'm still amazed when I go into the laboratory and see what the embryologists can do these days, and the videos of the embryos. This is the time lapse that Kathryn was referring to. We actually now, as part of our care maps, video the embryos so we can see them growing and developing, and importantly dividing. There is so much you can learn from those particular videos and observing the growth and development and how quickly they divide and how quickly they grow, and that is all fed into the care maps, and that's a real learning exercise for us, and it is for the patients as well, because they can see the videos and they can see their embryos and get to know how their embryos develop and which ones will turn into babies. I know that nowadays we have videos of babies that grew from 2 cells to 4 cells, and they're now being presented at their birthdays, aren't they? When they get their little USB stick of when they were a little embryo. I'm a bit conscious of time, so shall I just do one more question, Kathryn, before you carry on?
Okay, yes, that's good.
There's a couple here wanting to know about other fertility options such as Clomid. Well, of course, we Care Fertility offer the that's all we do. We are dedicated to fertility treatment. We don't have to run off and do other gynecological procedures or other medical problems. We're dedicated to fertility, so we can offer treatment from A to Z. And not everybody who first presents to a Care Fertility clinic needs IVF. Far from it. Probably about 50-60%. A lot of patients are referred for IVF, having been investigated elsewhere because of our reputation as one of the outstanding IVF clinics, Care Fertility now in the world. But there are some treatments that we that are far more simplistic. It may be just simple advice. It may be nutrition advice, just advice about timing of intercourse, weight, diet, how to increase your sperm count, or if a patient isn't, or if a woman isn't ovulating regularly and everything else is normal, we can give simple medications, oral tablets, like, for example, Clomid, which is a medication which fools your body into thinking that your ovaries have gone to sleep. And so you take the tablets and it alerts your brain and it goes, oh gosh, my ovaries have gone to sleep, because it blocks off the messages between your ovary and your brain. And your brain goes, oh, my ovary, I've got no more messages going through. My ovaries have gone to sleep. Therefore, I shall wake them up. And it pushes out a load more hormone. to get your ovaries to kickstart. It's like rebooting your ovaries to start releasing eggs predictably and regularly, and then all you have to do is to go home and fertilize them. So that's the benefits of Clomid. And for those people for whom Clomid is the treatment of choice, 50% will achieve a pregnancy within 6 months of taking Clomid. But if you take Clomid for 6 months, then and you're not pregnant, then the chances are it's not going to work, and it's futile taking Clomid for 9 months, 12 months, 15 months, because the chances are it's not going to work. And that's one of the important factors about fertility treatment. If that hasn't worked, move on. Don't go back. Look forward and get on to the next best thing that's going to give you an even better chance over and above Clomid. Your doctor or your nurse practitioner at the fertility clinic will give you all the information you need. And the important thing is that we give you the simplest treatment that's most effective for you. We start simple and move on. It may be that you need more involved treatment straight away, but the key is to get the right treatment at the right time to give you the best chance of achieving a family that you want. Do you agree, Kathryn?
Yes, absolutely. Yes, I do. Yeah.
Okay.
Yeah.
Well, I think that's exhausted my time. So shall I? I'll head off and leave you to it.
Okay.
Lovely to see you,
Thank
Kathryn.
you.
Nice to see you, everybody.
Thank you.
Good luck. And if you've got any questions, just leave them to our team, and we can answer them later on. They're on the line till about 8 o'clock. But of course, if you ever have any concerns, just pick up the phone and speak to our central team under Shah Short's guidance, and we'll be more than happy to answer your questions, no matter how trivial you think they are. They're important to you, and therefore they're important to us. Okay.
Thank you. Thanks,
Good night,
Charles.
everybody. Bye, Kathryn. See you. Bye.
So I don't know whether you want me to answer this last question. So I've got a question that I can answer. At the age of 30, we underwent a fresh cycle, 17 eggs collected, 15 fertilized, but only ended up with 2 good quality blastocysts. Is that the number you'd expect, or is that low? For starters, I think I can talk about the averages of everything. So on average, we collect 8 eggs per cycle. So to collect 17 eggs is fantastic. It's a really good number. I mean, it's over double the average. I don't know how many of those eggs were mature, but on average, we would say that 70% of the eggs that we collect are mature eggs, and then 70% of those fertilized. So the fact that you had 15 fertilized out of 17 has meant you were way over the average at that point for fertilization. Now, then I don't know whether you had the blastocysts transferred or frozen, and how many blastocysts you have. On average, we would say that 50% of the embryos fertilized become blastocysts. Now that could be blastocysts of any quality. The quality of the blastocysts is unfortunately the bit that we can't predict. So we could predict that 50% of them should become blastocysts, and if it wasn't, if it was 2 out of 15, that would be lower than we would expect. But if there was actually more blastocysts, but they weren't of a quality suitable for freezing, then it could be that it was what we would expect. We can only freeze and thaw blastocysts of a good quality because we know from experience that the grading of the embryo is what affects their chances of surviving a thaw. So we're very strict about what we do. Freeze. We would transfer those blastocysts fresh because it's absolutely only because we know they won't survive the thawing process. So I hope that helps in some way. As Charles said, all the other questions that we've had and that we haven't had time to answer, we will do that later on. And we'll now, I'll just do a short video from Shah and our CEO, and then I'll leave you because the phone lines are opened for the inquiry team until 8 o'clock. So thank you very much for taking part tonight and for listening and easing me in. I'm feeling a lot happier now. I've done one of these virtual events. So thank you for that. Okay, I'll leave you with the video.
I'm Shah, and I manage CARE's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose CARE was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with CARE that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to CARE.
Oh, the support at CARE was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success and treatment, we look to our own care family. From our consultants, embryologists, and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.